this is Roger Green, host of the Surfing the NASH Tsunami podcast. This weekend, we are offering 4 conversations from episode 6. Louise Campbell's interview with Dr. Tony Rahman, who serves as Director of Gastroenterology and Hepatology at the Prince Charles Hospital in Brisbane, Australia, and an adjunct professor at James Cook University. Plus, from the vault, conversation 23.5 from season 3, in which German patient advocate Achim Kautz and former GLI Vice President of Policy and Public Affairs Andrew Scott joined Louise, Jorn Schattenberg, and me to discuss what Achim and Andrew consider the 2 key areas for focusing patient organizing and advocacy. The entire fatty liver community benefits from NASH patient advocacy and the work of advocates, but very few of us understand what advocates do or how we benefit from their work. In this conversation, German patient advocate Achim Kautz and the then Vice President of Policy and Public Affairs at Global Liver Institute, Andrew Scott, discussed these issues. This conversation winds up focusing on 2 key areas for future organizing and advocacy. The first, they describe as thinking locally. Achim and Andrew point out that they can find success working with local and regional governments and then building up from those successes to a national discussion instead of starting at the top and working down. The second is clear, consistent communication between all stakeholders in the fatty liver community and between the community and the payers and government forces that we all need to persuade. This conversation fits with some of the elements of the broader episode, but in and of itself, it's worthy to sit back and reflect on how we've made progress since this conversation a year ago and how we need to make progress in the years ahead. So sit back, listen, learn, and when you're done, join the dialogue in our LinkedIn discussion group.
Louise Campbell.
Interestingly enough, on that point, there was a study released this week, which is a pan-European study, and Maud Lemon was the lead physician on the publication. They did it in mono-infected HIV with fatty liver, and they've come out the cap at 280, with in comparison to MRI-PDFF, does quantify moderate to severe steatosis. So we are getting more evidence now at that cutoff point. We're nearly there.
So my question to Achim and Andrew was going to be, if that's the world you live in, and of all the things you're talking about, and they're important, none of them are, here's what I can do for you next month. How do you make that tension work?
Maybe I can start. So I like tactics. That I like to juggle. And have different balls at the same time in the air. I have founded last year a global movement. It is the International Liver Cancer Movement, and GLI, you are part of this, and so thankful for that. And we have collected within 1 year more than 60 patient organizations, ASLD, APASL, EASL is part, Global Public Health 6. Using the hook of liver cancer, as you said, Louise, is something that is absolutely helpful also to addressing NAFLD NASH. So making a global movement not as an entity, because you as GLI, for example, you're a strong organization. We like to support you, but bring in a global voice addressing new possibility, having liver cancer in the attention to the politicians. And then, of course, we have the discussion, okay, how to avoid. The other story is, Roger, I think we were quite successful in a very, let's say, complex healthcare system like in Germany. We have managed that since last year. It is mandatory, is that in your annual checkup, hepatitis B and C testing is mandatory. So it's the only country in the world, so you have it. So means we are able to 2030, when we have our ultimate goal to eliminate hepatitis, we can screen, because of this checkup, around 40 million Germans. That is a number. And that is a number that I think when we had talked 12 years before, everyone had said, you are spleeny, you are stupid, you are naive, crazy, but we have managed. And I think one of the components here, Roger, is maybe also, if you think in the policy framework, you normally think on the governmental sector, but let's shrink it down to regional sector, a city sector. So there are politicians as well, similar to what we have done in HIV, similar to what we have achieved in hepatitis C as well, is a kind of micro-elimination. Make a city a liver-healthy city, something like that. Because what we need to establish, and I think that is something we have it, is best practice. But best practice is particular in a center. Jörn is doing a lot of best practice in this setting. So others is doing. But we need really to create more best practices that can be adopted to other local circumstances. And Roger, thinking about to politicians, coming back to local politicians. If I have a solution for my region here with a zero invest, but just the commitment of the politician to give his voice and say, hey, we need to align now, and all the best practices assistant can be pulled here together. Then I think we have more solutions. And that is something I think we need to think more in a clever way, not top down, but bottom up, to put stress to those top line politicians. Hey, on the ground, they have solutions. We can do the same. We must do the same. That is the message. And I think that is something worth to think about.
I would echo a lot of that. I mean, especially, obviously, our organizations are already working together on the liver cancer kind of perspective, especially underlining that. But the local side of things is critical. We have our Liver Action Network that is a majority U.S., of course, with one Canadian organization. But we're trying to work with them on the local legislators, because that is so critical, because they are many times community-based organizations, and how can they best interact with those local offices? A lot of times they're a lot more flexible. That's the only aspect that I would add as well, is that you talk about in a state or in a city, these offices are a lot more flexible in what they can do and a lot more mobile in potentially presenting opportunities for us to influence them. And then the last thing I would mention too, we have one advantage as advocacy organizations that many times clinical data cannot provide to legislators. And that is, again, going back to what we mentioned earlier, the use of story. While many times we can't highlight the numbers because the numbers may be too far out, they may be too large for legislators to grasp, or too small, or whatever it might be. If you have patients or loved ones or whoever telling a story and making the situation very real for them, these congressional or parliamentary or whoever they might be offices, and helping them understand the real problem, that's where you can hopefully influence in the absence of those longer term numbers. Going back to that, and obviously we mentioned that earlier, but still it's important to reiterate.
I get. In fact, you're reminding me of two of the rules that we used to use way back when we did this: is stories beat data every time. And after president, the most important election is mayor. People really care about their local communities. So all that makes complete sense to me. I want to do this. We're kind of at the bottom of our hour, so let's take one more question and go around. Closing question. Andrew, Achim, Louise, and your question and mine might be a little different. But for the three of you, given who our audience is, what's the one thing you would like them to take away that they can do that supports the work that you're doing? And then Jorn, for us, it's what's the one thing we can do?
I can start. Talk to each other. It is really the question of communication. Talk to each other. Bring all the stakeholders, all those who are interested and those who are currently not interested because they are not informed about the issue, bring them together. And I think the more you talk to each other and the more you break down the silos, the more success we have. It is really a question of communication, ongoing communication and passion.
It's always tough to follow, Achim. I think we've been agreeing so much and saying a lot of similar stuff, but I think that was going to be really my main point too, is that if we can just have everyone talk about the liver more in general. There's so many times that I've been in meetings with congressional staff, and to be honest, they can't point out where their liver is. And that is just a reality that we're facing that is even beyond NASH and explaining what NASH stands for. It's that just liver in general. And that is the thing, is that let's just talk, okay, liver, let's talk about it, liver health, okay, let's start thinking about that. Everyone, if we can just mention it, and I think that very much syncs up with Achim's point as well, but just let's talk liver.
I think I'm just going to echo what the guys have said. I think it's something that when I speak to people and they walk through the door, it's this whole thing about it has live in the title. In its name, it says live. There's a reason for that. There's also a reason it was the only organ our body thought was so important to make it regenerate. It's that important. But to me, and when I talk about it, make it fun, make it something people get empowered. If you know you can do something about it, you're empowered. There's a reason more people do health checks, because they have a risk factor. When you talk about it, when we talk about liver cancer with cirrhosis, they understand that they have a risk factor of cirrhosis for liver cancer. Therefore, they don't get too anxious about their tests. It's something that they're empowered to do. So yeah, let's talk about it, make it easy, but actually just know about it to start with. Everything that you do goes through it, basically.
Very interesting. And I think following up with the theme of talking, these days there are two ways of talking. You can make a lot of comments on the internet, social media, and these things move very fast. And I think they're in and out of perception. And I think it's important to actually sit down and see people face to face and bring this forward. Albeit, I just learned that there is a liver emoji on its way emerging. And I think that will be, of course, can also be a successful factor in raising awareness about liver disease. And I think while people were talking, I was thinking of the term a healthy liver is a healthy body or something, linking the metabolic liver health to a healthy person. I think that'll be crucial moving forward.
Yeah, so it's interesting. Your last tagline had something to do with where I was headed, which is I talked before about stories trump data every time, but you can actually turn data into stories if you know how to do it. So you have to say, here's how the numbers connect, and then make them about people and make them about real things that are tangible. I think that's the first piece, and that's something this podcast can do a lot more of. And in general, the reason this podcast has been around for as long as it has and has done so well is because I think there's actually a thirst for people to think about this stuff. And we learn as time goes by that our audience broadens. We started with patients, went away from patients for a while. We have more patients coming back to us now. We're getting to a place where people want to know more. And the ability for everyone who listens to this, since everyone who listens to this is in some way, shape, or form invested in fatty liver disease, to talk about it. And when your friends yawn and go, oh gosh, that's boring. So, well, no, that's boring. And turn it into a person that people know, turn it into a story people can connect to. Help everyone realize how real and how tangible this is in all of our lives. I think the thing we can do best, and the two, Andrew, Achim, hats off to you folks who've done a fantastic job of talking about the way you do that. I will tell you, when we promote this episode, I'm going to stress in promotion that lots of people think that what you do isn't about them, but they're wrong. It's about everybody who's in this space, and it's vitally important. And I think you've done a fantastic job.
I was going to say, that may also be the reality that every single one of us sitting on the podcast and every one of us is at risk of poor liver health throughout our life at different times. So it becomes a reality that it's one of those conditions that everybody can suffer from, and that includes us. Just because we know about it doesn't mean that we're not at risk of it. That's where advocacy comes in for me, and what these guys do is amazing, and anything that we can do to help support and drive people to it is absolutely key, because that's where they get so much support. So hats off to Andrew and Joachim and Donna and the British Liver Trust and any of the societies around the world, because that's where the real help comes in.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to questions@surfingnash.com. We'll be back next week with a discussion of the recently pressed AASLD guidelines and how they relate to the important need to bring frontline providers who treat the patients with diabetes and obesity into this discussion. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.